I don't think you want a pathologist to teach pathology. I don't think you want a cardiologist to do heart. Here are the two hardest things when you come to teach a medical student out of practice. Number one, what can a medical student reasonably know? It's less than you ever think. The second is, what don't you teach? Well, if you're a cardiologist, you go, oh, well, you've got to know these reentrant supraventricular tachycardias. Who couldn't know that? They can't tell you the difference between the conducting system and the contracting system. No one understands if you overteach something. If you teach something that's too much and too deep, your student will memorize it and forget it. It's not just that they forget it, Allie. It harms them.
Dr. Tisdall, we've gotten a lot of comments asking whether this way of learning, who it's for. Is it just for physicians in training, or can it apply to nurses and pharmacists and stuff like that?
That's a really good question, and it's something that I think about a lot. When you do step one training, one of the really interesting groups that I taught were physician's assistants, PAs, who had gone back to medical school in their 50s. And one of them I spent a whole week with, so we talked every day at lunch. And I said to him, so you're seeing 30 to 40 patients a day. You're making more than most GPs. So you are a practicing physician, even though you don't have an MD. So why would you go to all that trouble and effort? And he said, because in my hospital, for me to become responsible for decisions and committees, administration says I have to have an MD. And, my kids have gone, I've saved enough money, and frankly, I think I want to run things. And so he went back to get it. So he and I talked a lot about what's the difference between an MD and a PA. And I've had this conversation with nurse practitioners. It's a really good discussion. And I would tell you this, and everyone's allowed an opinion. This is just an opinion. I believe that an MD says, you have mastered this body of knowledge. And in mastering this body of knowledge, it allows you to make judgments on change. In other words, what this doesn't say is you're competent to treat hypertension. Because nurse practitioner, anyone's competent to treat hypertension. You can look it up on AI. But when you say, we're recommending whether we add this drug to your calcium channel blockers, and we have this new drug, what do you think? I would argue that's a responsibility that requires judgment for your specific practice. And I believe that should be our goal for training an MD. There's a very interesting concept in the military called being a warrant officer. And so when you say, what's the difference between a line officer, a warrant officer, and enlisted? And a line officer is someone who can take command. So if the colonel's dead, the major's dead, the captain's dead, the most junior first lieutenant, as the English would say, or lieutenant, becomes the person in charge. The helicopter pilot, who has this fantastic skill, he's a warrant officer. He's never in charge. And so I think we kind of also have to differentiate with this idea of you can be a great technical expert. That doesn't make you responsible, something that requires judgment and leadership. And so when I say that, everyone can quite rightly point out, well, that's not what anyone else's MD means. The answer is no. That's one of the reasons I'm in medical education is I think we need to define what we mean by MD. So I'm going to put it out there. You can be a highly skilled warrant officer. It doesn't make you an officer. And that's what that PA was saying. And, one of the really fun things we did was, he sort of had a chip in his shoulder, right? I mean, I've been practicing for 20 years and now I have to do biochemistry. And I would tell him, if I can't make you a better doctor by teaching you my biochemistry, I will pay for your tuition for this course. And so we went through biochemistry and went, okay, yeah, that's pretty good. So yes, so I am very disruptive and very revolutionary. And I recognize I come under very severe pressure. And it's really uncomfortable dealing with our current medical way of teaching because the standard is 2 years of preclinical. That's our basic medical sciences, disproportionately taught by PhDs. And then big transition after your exam, you go to your clerkship, which is all MDs. And it is impossible to get the PhDs to understand you're training doctors, you're not teaching your subject. And I had a very discouraging meeting this week, and I'm feeling quite down because we had a meeting for changing. Here's what we did first year in neuroanatomy. Now we're going to second year, which is neurology. What should be different in how we base this on neuroanatomy? And it was me and 3 PhDs. And they simply couldn't accept that you start with a patient in neurology. And when I said you shouldn't teach any neuroanatomy, you should teach the neurologic physical exam and imaging. And, they put me in a position where I was going to have to be quite confrontational. So I just backed down. But I felt quite discouraged because I feel so bad for the students. They're going to be learning all of these obscure neuroanatomy tracks that have no meaning. And, I was so discouraged, I called my professional friend Nancy, whom we've interviewed, and I said, well, that was really unpleasant. And we got into quite a good discussion about, is there something special about neuroanatomy where they fall in love with neuroanatomy and believe that it exists in and of itself? And after going back and forth based on our many years' experience, we concluded, yes, they are different. And they do believe that neuroanatomy exists for the sake of neuroanatomy.
You've mentioned that no one owns anatomy, no one owns pathology. What do you mean by that?
Yeah, nobody owns anything. So it goes back to this idea of what is competency. So, I was in hospitals for 35, 40 years. And because I was a hospital-based pathologist, you're always around, right? Because you practice in the hospital, which means you're on every friggin' committee that ever existed because they can just pluck you out and say, hey, we need a body for this committee. It's got to be an MD. And practicing physicians, I'm going to knock off my office. I'm going to take 2 hours out of my day. It's brutal. Pathologists, you go, yep, you go right there. So I've been on every committee ever designed by God in hospitals. And there are 2 committees that really matter. The first committee is the practice committee, which says, do you have the credentials to do this in our hospital? Because that's your livelihood. The second is the quality committee. Did something go wrong? We have to talk about why that went wrong. So, those 2 committees were my life. And the big change that went in credential committee was this. We started off with nuclear medicine, for example, could be done by radiologists. We'll just stipulate they're good enough for it. Well, sure enough, nuclear cardiology came, and the cardiologist came and said, we want to do the nuclear cardiology. And they argued, we know tons more about heart than those radiation guys. Well, believe it or not, in the Northeast, it used to be done by pathologists. And so I did it. And you sort of go, well, how would a pathologist be qualified? And the answer is because I went and trained specifically for many months in a major center to qualify. So you get to say, who owns nuclear medicine? Well, is it radiation? Is it just some random pathologist who got really good training and is good at it? Or is it the cardiologists who own the patient? And we went through massive wars because that's people's livelihood. I mean, there's real money at stake. And so it wasn't just a question of what was safe for the patient. That was let's stipulate that. It was also who gets to control it and do it. And by the end, it was you show me the training. You show me then the supervised experience for a given number, and you're qualified to do it. Nobody owns nuclear medicine. Nobody owns vicious wars over endoscopy. Is that coming out of GI? Or is that can surgeons do it? Wow, we saw violent actions. And by the end, it was, if you show me your training and you show me your supervised experience, anyone can do it. So I bring that real world sensibility to the subjects of medicine. Who owns anatomy? Well, not the anatomist. I can go learn anatomy. Anyone can go learn anatomy. Here's a book. Here's a model. It's, show me that you've mastered it. And so, I've come to believe, just for an example, I don't think you want a pathologist to teach pathology. I don't think you want a cardiologist to do heart. Because here are the 2 hardest things when you come to teach a medical student out of practice. And I'm telling you, 12 years later, it's still hard. Number 1, what can a medical student reasonably know? 12 years later, I can tell you less even than my 12 years experience has taught me. It's less than you ever think. The second is, what don't you teach? Well, if you're a cardiologist, you go, oh, well, you've got to know these reentrant supraventricular tachycardias. Who couldn't know that? Well, I just had some students ping me on it, and my first one says, oh, you poor souls. You know, they can't tell you the difference between the conducting system and the contracting system. And now they have these complex bidirectional, oh, it was just like, no one understands if you overteach something, if you teach something that's too much and too deep, your student will memorize it and forget it. It's not just that they forget it, Ali. It harms them because now they've learned to memorize and they haven't been building foundations up. So it's been a discouraging week for me.
So if these experts shouldn't be teaching their subject, who would actually qualify as a good educator?
So you know who I think should teach pathology? I think a good internal medicine doctor that's been in practice for 20 years. She would be great. She's seen lots of disease. She understands that drugs teach you mechanisms of molecular. She's done a wazoo out of testing. Testing teaches pathophys. But, you know, they're really intimidated to do it because they don't have much histology. Well, they don't need to know histology like I do with, 40 years of microscope. They just need to know, draw a cartoon of a hepatocyte. You don't really need to go onto your microscope and identify 13 different types of pathology. So I would rather have a good internist teaching good testing and molecular pharmacology than a pathologist, because I'll tell you what they do. They teach you 20 testicular tumors. Oh, just don't. They're going to teach you all these ovarian things. Oh, one of my very funny stories. So I'm in a different medical school, and we used to have Harvard neuropathologists come down and teach tumors. Can you imagine their level of expertise? I mean, they're seeing every brain tumor in the world all day. And I happened to bump him. I liked him a lot. And I bumped him in the corridor as he was going to teach. I said, oh, what are you teaching today? He goes, I'm teaching brain tumors. I went, ooh, brain tumors. Let me see. There's a bad one. There's a pretty bad one. There's a move the marble one. And then there's little kids. And he looked at me and said, wow, I wish I had time to redo my lecture. Those poor students, he crushed them.
Well, we had one commenter who was a nurse, so clearly was in patient care. And now she's in med school. And she's just amazed at how all of her fellow students are really priding themselves on how they've memorized the cytokines by abbreviation, but then they're not able to explain basic disease concepts. Why do you think that's such a common outcome of the current system?
Yeah, so teaching EMTs and nurses carries its own challenge because they're so deeply into patient-centered learning that they go to classes where they're doing molecular and they go, this is stupid. Let's get to the patients and the real stuff. Missing the start of our conversation. What is an MD? It is someone that can bring any change, and they're all molecular now, and say, tell me how that affects my patient population, which means you can start with a patient and you can do what we've discussed as completeness. Psychosocial, cultural, organ, internal structure, architecture, cell, ultrastructure, protein, DNA. You've got to be able to do all of that to say, I understand a disease. And of course, my EMTs and my nurses, they've done all sorts of real medicine, stopped at the organ. So you go to say to them, hey, walk me through this molecular, and they go, you don't need that. Well, the only reason you believe that is no one's ever taught you why you do need that. And I'll give you an example. Here's an example that I used to teach. So you have someone with an aortic aneurysm. Abdominal aortic aneurysm is atherosclerosis. Here's what almost no surgeon will tell you. It's an inflammatory disease. And so when you say, what is the prognosis of your aortic aneurysm? I would say, tell me how much inflammation it has. So here's the question. If it's the disease that's associated with a blood lipid, which would be better for all your patients? To decrease the blood lipid or to target the interleukin that's pro-inflammatory? Well, I guess cytokines do matter, don't they? Because the answer is they both work equally well. So I can promise that nurse, yes, you do need to know it. The world is moving to these targets in drugs. But I also can tell her she's completely right. None of those medical students can tell you why they learned it. I know. I see them every day. I talk to them every day and go, hey, tell me why. Got nothing.
So, okay, so let's rewind for a second. Now we have not someone who's in med school, not someone who's trying to be the leader, not trying to be an MD, a nurse, a pharmacist, whether they're in training early in their career, what have you. If they studied the med school companion and the textbook, will this benefit them in some way, make them more valuable? How do you see this applying to them?
This is completely agnostic as to who should learn it. This is medicine starting from a patient and walking through the molecular, no gaps. And it starts with, if a patient has these symptoms, how do I get to the disease? And the other half is, once you have the disease, it flips it and says presentation, pathophys, natural history. It's agnostic to who learns it. Anyone that wants to learn medicine can learn from this book. That's, I sort of have this deeper dream, and, you guys that are sort of pioneering with me doing this, I've sort of asked for one legacy. If we ever did well and made some money, after I'm gone, one of the things I would love to see us do is take this to people and populations that have no medicine. If we have we have 9 billion people in the world. Say 1 billion have our level of interventional medicine. Another 1 billion have the penumbra of that. Allie, there must be 7 to 9 billion people with nothing. So I love the people that do these missions and fix the babies with hair lips. I love those people. But, that's taking a teaspoon to an ocean. At the end of the day, resource-poor nations are going to have to teach themselves. And so I think that you can take this, and anyone in any country can teach themselves how medicine works from this. And so one of the things I've always believed would be a happy marriage would be for us to start hospitals where there are none and pay the medical staff so they had time to teach. And then they could teach their own kids, and we could send our kids so they could see real medicine. Like no one sees deliveries anymore. It's sort of become a very private, don't want hairy guys with beards in there during that very personal moment. I get that, but it doesn't help that medical student learn obstetrics. So I think there is a great opportunity for us to go to a resource-poor place, and we can do disease, and they can teach us and get medical care. And it all comes down to this. Clinical medicine is built on a foundation of basic medical sciences, and the guts of that is pathophysiology. If you can do pathophys, you can do everything.
You gave me a quote the other day that said, something like, it's hard for a man to see something when his livelihood depends on not seeing it. Yeah, tell me about that.
Yeah, okay. So again, I was at another medical school. I had a very discouraging meeting. Apparently, I'm on a run of really discouraging meetings this week. And in it, they were talking about how late in second year, so the students are getting ready to transition to clerkship, seeing patients. They have what they call integrated learning, by which it turns out everyone has their own definition of integrated. Because you know what their idea of integrated was? Each PhD would do multiple choice questions in their subject. Well, that's the opposite of integrated. There's not a thing going to lie in that. So you ask yourself, these are very well-intentioned, very knowledgeable, very able people. Why would they do that? And you have to ask yourself, well, how are they going to walk back using an anti-IL-1 to treat an abdominal aortic aneurysm if they don't have a good feel for all the upstream part? Here's our patient, here's our screening, here's our smoking risk factor, here's the ultrasound, here's the pathology definition. Don't confuse true aneurysm with pseudoaneurysm. They can't do any of that. So how are they going to do integrated? Well, the answer is they can't. And so the quote is, I believe, from Upton Sinclair, who said, "It's hard to convince a man to see something when his well-being depends on him not seeing it." So it's kind of, I don't know how you bring that change. I've tried it in many institutions who all want to do integrated, and then you point out to them integrated means that the teacher can go right across completeness. And they look at that and go, well, I can't. And they vote me off the island.
Why do you think it's so threatening to them to suggest that maybe their way of teaching is flawed? Like, why are they so resistant? You've talked about it before with Nancy, I know, in the podcast.
Because they can win politically, and then they don't have to go through all the difficulty of learning. Remember how we've talked about learning hurts, knowing is fun? And learning, we know when you're a 40, 50-year-old and you've been a subject expert for 20 years, you just don't want to look like an idiot. I mean, you don't know any better than your medical student. And they view that as embarrassing. Whereas doctors, who are embarrassed every day by what they do, every time you ask a consultant, they embarrass you in some way because they're subject specialists. So medicine is nothing but little embarrassments every day. You just learn to say, nope, didn't know that. And for PhDs, they've been subject experts. Imagine saying you don't know any more than your medical student. So, I'll tell you what it's like. I've told you this in another story. I was teaching in a med school and happened to have a non-teaching break of 3 weeks, which overlapped molecular neoplasia. And I'm old enough that came in the last 5, 8 years of my practice, so I was terrible at it. And so I said, this is great. I'm going to go learn it. And I went to that class. I've told you this, and it made no sense to me. I didn't know a single word they were saying. And so on break, I went and taught myself molecular neoplasia. And when I came back, I wrote the exam that my cohort of students had written, same exam. And their class average was 82%, and I got 64%. Now, did the PhDs say, wow, this practicing pathologist who has run tumor board every week for 40 years, having studied this for weeks, got 64% in my exam? What conclusion did they come to? A, it was a stupid exam and he only learned what mattered. Or B, he's kind of a moron and this is the funniest thing we've ever seen.
Definitely just as obviously assume that you just weren't that capable or weren't that smart.
Well, they knew that wasn't true. They knew that wasn't true. They'd worked with me. They knew I was perfectly bright. And yet they did it anyway. And Ali, they kept it up for 2 or 3 years. That was a standing joke. And it was their way of letting anyone see what it looks like. If you try to learn something new, what's going to happen to you on the learning curve?
What do you think the moment is when students or medical educators finally realize, oh, this actually works? I know you've had a lot of people where it finally clicks. Like, what is it that they see? What is that moment?
Well, the single best thing is they fail. So one of the groups, most schools have really high pass rates because they make you write a screening exam to prove that you can pass. So anytime you see a school say, oh, we have a 95% pass rate, you should ask them, what was the pass rate on your screening exam? So, for example, I know generally since the step 1 has become so clinical, the pass rate on the screening test that most schools use has gone from about 80% when I started to about 20% now. Because the students are learning subject-based data that's memorized and memorize and forget, and the step is a clinical exam. And so for the first time, the students come in and they just can't do it. And so those are very willing students. They recognize whatever they were doing, they're failing. So that's a really good group. The second good group are students that are actually very good students, and they're so frustrated because they feel that they just don't get what's going on. That nurse is a good example. And when they get to me and I say to them, well, let's go to how we think about ischemia. They go, well, that makes sense. Those are delightful students. They just sort of go this, well, thank God I can do this. But all the rest of them, they tell you, I got my plan, I'm sticking with it.
So if a non-med student, let's say a pharmacy student or a nurse, wanted to start applying this tomorrow, What's the very first thing that they should change about how they study?
That's a great question. The answer is, first of all, they have to ask themselves if they're ready for the pain. You know, if you're 15 pounds overweight and you're going to start exercising, don't tell me you think it's going to be easy. Learning hurts, knowing is fun. So remember, you're going back to the beginning. You're going to feel like you should be embarrassed. And I have to tell students, every lecture I ever go to, what is a medical student expected to know? Nothing. You can't embarrass yourself. I have zero expectations. Now, if you get something right, ooh, nice, good job. If you do something really funny, thank you so much. If you just participate by throwing out idiotic answers, thank you, because it's a performance art. I need interaction. If you bring coffee and muffins, well, then you're my BFF. But are you expected to know anything? No, you're not. So if you're a pharmacology student and you're coming in, what I would start with is go for the easy wins. So for example, if you can do glucose metabolism, you can do all the type 2 diabetes mellitus drugs. If you can do the body's response to hypotension, you can do all the CHF and hypertension drugs because they all fall onto that pathophysiologic image. If you come and do the image of how the body processes lipoproteins, you can do all your hypolipidemia drugs. They plot right there. So I would start with, go to the easy wins. If I learn this pathophysiology, my drugs all of a sudden become a picture that's really clinical. And save for the ends the drugs we just don't have good stories for, like thinking mostly the CNS drugs.
Final question for you. What thing should med students, pharmacology students, nursing students stop doing immediately?
Highlighting.
We talked about this last time too. I used to be a prolific highlighter.
Highlighting says, I'll learn this later. Oh, this looks important. I'll learn it tonight. No, you won't. The second thing I would tell them to stop doing is stop thinking classes are boring. You don't have any time. The old expression, you're drinking from the fire hose. And so when you go to class, that's your first cut at learning. I don't care how bad the lecture is. I just don't care. Have a book there, have your phone with AI on it, and say, I've got the topic. I'm going to set this up for tonight when that's my last chance to learn it. So you should have a third of your learning done by the time you leave that class, no matter how boring or how thick the accent is. You've got the topic and you've got a standard textbook that has the data. Do it now. There's no time to do it later. That'd be the single biggest thing. And then the hardest thing to do, which is why we exist, which is tell me why you're learning this. Why would a doctor need this in patient care? Ooh, that's when you're going to have to come to us because nobody else talks about it.
So in breaking news, the textbook 2.0 is going to be available really soon. Do we have an exact date yet, or we're only approximation right now?
Days. I've been told days.
Days. Okay. So check the links. I'm going to update all of the links in all the descriptions for all the videos we posted so far, switching them over to 2.0 once that book becomes available. And there's always a volume 1 and 2. Okay. As well, on my side, me and my team are actively building out the 2.0 of the community. So on our Med School Companion website currently, there's a version 1.0, which is fantastic. It has an excellent question bank. It has a plethora of videos for you to watch and lectures. But 2.0 is going to enhance that even more, and it's going to allow Dr. Tisdall to go live, either small group sessions where everyone else can watch or just purely going live. And it's going to be an excellent resource. So if you're interested in that at all, be sure to hit subscribe because any updates and news on that front will be talked about on this channel. Other than that, guys, keep leaving your questions. We're getting so many good questions on every single post. If you leave a question, it's very likely that we're going to be talking about it because we want to be able to keep you guys in the loop on sort of Dr. Tisdall's thoughts on medical education and how to approach your learning and everything like that.
Well, I just want they can take small comfort in the fact that I'm getting as beaten up in the system as they are. So don't think you're alone in your why is it this way.
Thanks, Dr. Tisdall. We'll see you next week.
All right, bye for now.